First of all, what is therapeutic alliance? Well, really, it's in a relationship that exists between a healthcare provider and their patient. It's defined as a sense of collaboration, sense of warmth, and support between a patient and their provider. It's a rapport that's developed through skill, communication, and the clinician's ability to reflect and listen. A strong therapeutic relationship is marked by a clinician that not only listens, but sends appropriate messages and even makes physical contact with their patient. It's tied with just time spent with the patient, showing up and listening and being present. It's also marked by a warm and empathetic response to the patient, not just mechanical yeses and nos and questions. But thankfully, it's not personality. Research shows that if PTs follow a given therapeutic alliance protocol, it's just as effective as physical therapists who come by it naturally just within their personalities. So, no fears if you're straightforward, blunt, not very warm and fuzzy person. You can follow protocol and develop a therapeutic alliance. So, why do we care about therapeutic alliance? Because there's a certain amount of unknown in why some patients improve and others don't. Research has shown that specific treatments account for only some of the effects found in outcomes. Relationships seem to make that extra difference. This is consistent with previous studies done in geriatric and neurological rehabilitation, and the phenomenon has been well studied between patients and their psychiatrists and physicians. While there are several systematic reviews that are specific to physical therapy, which show that there's a moderate relationship between therapeutic alliance and pain relief in chronic pain patients specifically. Well, there are these systematic reviews, but it's difficult to draw conclusions because the qualities of studies wasn't amazing, and the definition of pain and the definition of chronic pain varied drastically from study to study. Like a lot of physical therapy research, there's work to be done to really make these principles more concrete. But there are several random control trials that are individually strong that lent a lot of helpful information to this topic. Ferreira found that therapeutic alliance in the treatment of chronic low back pain was predictive of pain intensity outcomes. He used this scale, this measure of therapeutic alliance that's psychometrically sound. It's called the Working Alliance Inventory. He used that and found that one standard deviation change on the scale correlates with a 0.5 unit change in intensity on the numerical pain rating scale. That's a pretty good prediction. Another great study by Fuentes showed that playing with varying, he played with the intensity of therapeutic alliance and found that it indeed has a causal effect or causal relationship on pain intensity and pain pressure thresholds in chronic low back pain. So he had four groups. There was a low or minimal therapeutic alliance with inferential current therapy. Then he had a low or minimal therapeutic alliance group with a placebo treatment. Then he had a high or strong therapeutic alliance that he matched with the treatment with ICF. And then he had that same optimal therapeutic alliance relationship with a placebo treatment. This is really interesting. 77.8% pain intensity improvement occurred when when the high therapeutic alliance was combined with the active treatment, compared to only a 45% intensity improvement when it was just that active treatment alone, the ICF. So, therapeutic alliance plus that active treatment was drastically better than just the active treatment alone. He also looked at pain pressure thresholds and found that the pain pressure threshold was 51.5% higher than the maximal for that therapeutic alliance and the treatment group versus only a 32.6% improvement when it was just that treatment alone. So again, adding this therapeutic alliance, this strong therapeutic alliance relationship shows huge improvements in tolerance of stimuli as well as reduces that pain felt. Basically, I really want you to remember that a meaningful clinical difference for the NPRS is 1 point. So the fact that a moderate improvement in a therapeutic relationship is so tied to a meaningful change in pain intensity is big. Those random control trials, they also individually had large effect size for therapeutic alliance. So we care. It means change. A therapeutic alliance means change for our patients. So gosh darn it, it's important. How do we form it? What if you're just not a naturally bubbly and warm person? What if you're like me? That's okay. Research shows, remember that personality doesn't predict the strength of the therapeutic alliance. You can still formulate a healthy bond by following some tips and tricks. In the interview, really, it shouldn't be just a collection of medically important facts or a barrage of questions about symptoms. It can be a great opportunity to incorporate empathy, which is the ability to perceive and understand a patient's experience. Ask questions about how their pain impacts their life, their relationships, and concerns that they might have about not only how their pain is impacting them, but also how treatment could impact their pain. Also, listen to their patient. Active listening and motivational interviewing strategies can definitely be used. You've had this in PT school, and I'm sure incorporating this into your practice now, but this is just to reemphasize. Things like summarizing and restating to clarify and show attention go a long way. Give patients time. For an interview, expect 20 minutes minimum, especially with this population. It's just being present and having that time with them is therapeutic. Identify patient expectations of treatment. Know what their attitudes and beliefs are because it can really significantly impact outcomes. Knowing what they want and what they hope for can guide your treatment as well. You're done with the interview, move on to the exam. Imagine a chronic pain patient. Got one in your head? Well, they've been through so many providers for that one issue, and they've likely been told by many that they can't be helped, that there's not something wrong on a tissue level. They've been passed off from provider to provider and often turned things like repeat offenders or frequent flyers. So don't do a quick haphazard exam, assuming widespread pain is the issue and not digging into anything else. This communicates flippancy. The opposite of empathy is apathy. Also, the reverse is true, though, as well. Don't overdo the exam. You don't want to communicate harmful messages like their problems are chiefly tissue pathology. Don't include unnecessary exams that point to that tissue pathology, and which in turn increases fear and is ultimately not helpful for their outcomes. Often a low-tech, thorough exam can be done in 10 minutes, and it develops confidence and trust between a patient and the provider. After the exam is completed, thoroughly explain your findings without fear-inflating words like tissue pathology or tear or rupture or any of that. And above all, watch your language throughout all of this process. Speak with compassion and always from a pain neuroscience perspective. Your goal is to decrease the threat of pain through avoiding words that heighten fear avoidance beliefs, heighten their anxiety, etc. Remember that just being present is powerful. Spend time with your patients. Pat their knee. Respond with warmth and empathy. These few things, time, empathy, and humanity, and can significantly improve your patient outcomes and make your work life-giving rather than frustrating.